Ppo Health Network is headquartered here in Plano, and they are an integrated clinical network. Within that network, they have over 1,000 primary care physicians in 300 locations. They currently serve 1.5 million patients. They operate on an integrated care model. That is to leverage the primary care physicians, have a complete care coordination management team, and data-driven, and pharmacy as well, to really kind of help the clients and the patients primarily within a value-based pay model. Some of them are from the commercial employer side, and some of them are from the CMS side, the provider groups, or the payer groups, and in those three markets. So the next slide, MediBooker to the employer side, really focus on providing navigation and engagement to the employers, to help the employers, members, patients to better navigate through the complicated health plans, the care journey, to achieve the right level of engagement so that the members can get the care they want at the right time to the right providers who have the right cost, the right quality, so that they get taken care of at the right cost. And so you can see kind of in this conceptual figure, you can see MediBooker integrate all the complicated elements within a health care plan. Whether it's the providers, the plan, the deductibles, all of them digitally into the model, and then come out in a very simple way for the users, whether the computer or the mobile, the members can easily access that. So that's what MediBooker does. So merged together to look at it from a patient journey perspective, kind of this give us a linear kind of picture. What does it do for the employer, and what does the patient see from that perspective? From the very beginning, benefit plan visualization, instead of employees having a whole stack of paper about benefits, deductibles, everything, the patients see that digitally, right? Oh, this is my deductible. I get onto the mobile app. This is my copay and all of that. So all the way match the patient with the right primary care physician at the very beginning. Allow the patient to compare providers. I founded the MediBooker to provide comparison of providers, price, quality, certification. And that's how I started MediBooker. This was 6 years ago. To really give the user that transparent picture. What is my plan? If I need a CT scan, what are the different rates among the providers? Cash rates, if I were to use my plan, what are the rates? If I were to do the deductible, what is my portion? And that's what MediBooker was trying to do. And then along the journey, integrated telehealth, as we know, almost 2 years later, a year and a half later, after COVID, we have all learned virtual care is important. We look at the future of care. How do we better navigate the patients, reduce cost? And we all kind of see the value of virtual care first. You got an issue, let's connect you with a doc, with a care coordinator or a nurse first, virtually, instead of sending the patients through the loops, get an appointment after several days. It just doesn't solve the problem quickly, right? And then, so all these tools solve that, allow the patient to easily access the right providers at the right time. And provide that clinical disease, chronic disease support. All the clinical team are there to support the patient along the journey. And medication management, Catalyst Health has a whole pharmacy, relationship-based, team-based. Anytime the patient need help, it's not like go to Walgreens, go to CVS, you just fill the prescription. The pharmacists are there to answer questions and navigate the patient, to do the right thing, etc. All the way to the end, 24/7 nurse line, and help that patient. And that's the kind of the power. That's why we merged with the Catalyst Health Network. Before that, we were just the navigation, the engagement solution. Now we merged, then we can do all of this for the employers, for the members, all together to achieve what we all wanted, reduce the cost, simplify the journey for the patient, have the team along the journey for the member every step of the way to achieve that desired outcome. That is to get the care at the lowest quality, at the lowest cost and the highest quality. So the next one. So the challenge we tackle, and I think in this room, we probably all kind of see the problem. If you ask the employees about, hey, do you understand your benefits? Despite that, all that information, we find 76% of the employees, they don't understand it. And they don't have the time to go read it. Even the tools, we give it to them, they don't download the mobile app and say, oh, I'm gonna spend an hour navigate through. They just don't, until they need it. Then they say, I don't understand it, help me. And that's why we found out the patient advocates, the care coordinators are so important. It's not that patients are not diligent, it's just our healthcare is too complicated. So we need people to navigate. And that's one big challenge that we see. The second challenge would be 40% of the members are just misaligned in many different ways. So we need the advocate to navigate them. We need the tool to make it easy at their fingertip to access that. And finally, we all know with any given population, about 20 to 30% are rising risk patients. We don't even know, but they are just on the verge for many different reasons, and they are not aware. And it is the higher risk patients, 5 to 10% consumes 2/3 of what the employer's cost is, and we all know that, right? So we found out one of the keys to reduce cost is to catch those patients who are on the verge to become high-risk patients, to prevent them from becoming a high-risk patient, like a patient, high blood pressure, high sugar level, all of that, about to have a catastrophic patient. How do you catch that patient to get the right medication to bring the sugar level down, to bring the hypertension down? How do you do that? We need to just understand the patient, need to have the advocates on them, be there when they need the help, navigate them to do the right thing before they hit that point and they have to go get a $60,000 heart surgery. And that's what we're trying to do. So the next one, these are the challenges. And what do we do? To put it simple, I've kind of gone through that journey in a simple way. We make a price quality transparent through our platform, through our advocates. We make that process streamlined, both digitally and also by the advocates. It's a dedicated advocate for certain population. So whenever the employee call, it's always that advocate. If that advocate is not there, it's always the backup team. And then navigation made it simple, both digitally and manually through the advocates. And the advocacy made it personal. The advocates get to know the patient, who the patient is, what is the profile. And they work together as a team. That is the physician, the medical assistant, the care manager, the nurses, the pharmacist, we build that whole tool, and that's why Catalyst bought MediBooker, because that whole team-based digital platform power up that whole team, not just one, but that whole team work together. Imagine the patient is in the middle. The whole team surround that patient. The same team surround that patient and serve that patient's needs. And that's what it can do. So the MediBooker solution so I use the city of Euless as an example, and they have a complicated health plan together. And then we digitally tier up their health plan. We were able to engage more than 44% of their members, and NPS score is above 85%. And through the cash paid saving programs, we are able, on average, to save $1,100 per case for the patients. And the first year adoption is 2 times ROI. Basically, if you get a MediBooker solution, the outcome, the money saved pays for itself, even if there is a few dollar PPM, if you compare that. So the next slide, just to use an example of imaging, we all know there's a whole list, and Todd will talk about it. There's a whole list of care. Cash rate is only a fraction of the traditional booker rate. Imaging, as an example, and I use real names. These are the imaging centers in the DFW market. You can see the rate difference. These are not crazy numbers. What the big variance is, the big variance will come down, for instance, surgery, hip knee surgery, like in the Oklahoma Surgery Center, and the rate between that and the hospital rate, as we all know, it's multiple folds. You go there, it's $10,000–$15,000 for a hip knee surgery. You go to a major hospital like here in DFW, any of the big boys, it's north of $60,000, and that's what we're looking at. Navigate the patient to the cash rate providers, away from the hospitals, and have the right TPAs to work with. And we all know Campton Group. That's one of we call in Star Wars analogies, those are the good guys, right? What do you call them? Jedis, yeah, Jedi. We're all Jedis. I believe we're all Jedis. We're all trying, as employers, 80% in the audience, you're an employer. You don't have to do anything. You still get paid. You are here, you spend time, and you're trying to figure out how to help your employees. We all have the heart in the right place. We're all trying to make this work. And that's what it takes. The right TPA, they not only process the claims, they also show the cash rates. They also help the employees process the cash rate payments toward their deductibles so that employees save, employers save. And that's the power of that. And so the information here is based on real data. And so the next one, basically the Catalyst Health Network has helped the local communities here saved over $100 million through the primary care management model, etc. So that kind of is my portion. If anybody needs to reach me, you know how to reach me, so I'm gonna sit back.
I'm Kelsey Reneau. I'm the HR director at Chaparral Energy, and we are, as a company, still pretty new to a lot of this, and we're still learning along the way. But I wanted to share with you all today some of my experience in kind of navigating through this healthcare system. So in the middle of 2017, I took over all of HR for my company. And prior to that, I was primarily in HR operations, compensation, things like that. I really, like a lot of people maybe in the room, I really didn't want to touch benefits. It didn't sound like a lot of fun. It didn't look very sexy. It was just, you know, and also too, a lot of people that worked in benefits just, you know, really didn't seem to come to work with a lot of joy either, right? So I was like, oh, you know, I'm good. So I unwittingly took over the program in 2017, and if you'll go to the first slide for me. And so a lot of the things that I do as a professional, my team does, our organization, is we try to follow this continuous improvement process, right? Where we look at the status quo. Hey, we have a problem. How can we fix it? Let's implement something, and just keep continuing, just keep following that loop. And frustratingly, I found with healthcare, like I said in the middle of 2017, was that I could not make this loop work, no matter how hard I tried, right? And I think what was really helpful too is that I was pretty ignorant to benefits, right? I had never done it. I'd never been involved in it. And I'm also not afraid to admit that I'm kind of stupid, right? I really wasn't afraid to talk to our brokers, talk to Blue Cross Blue Shield and say, I don't understand. This doesn't make sense. And like what Sunny said, on most employees don't understand their benefits. I didn't understand our benefits plan. It was complicated, right? The way it was actually put into practice didn't make sense. When I went to a doctor, I got a surprise bill. And I can even point to my own experience. I had a little girl that came about 6.5 weeks early, so she had to stay in the NICU for 3 weeks. And that surprise bill that I got at the end with the itemized things that she never had done, right? And never had these procedures. I was there 12 plus hours a day. I can promise you all these things never happened. I'm like, now wait a minute, right? So that was kind of one of the first eye-opening moments for me. So if you'll head to the next slide. So kind of a timeline of how we've transitioned and evolved to where we are now is that in 2018, I really buckled down to work with our broker. I brought in our broker. I brought in our Blue Cross Blue Shield folks. I brought in, the folks that ran our prescription benefits to try to understand what the heck, right? Why are our costs continuing to soar despite all the things you've told me? The broker, they had all these discounts they were, giving and, we can get this, we can get that. And to me, and I even told one of them, this sounds like a scam, right? Like, what do you mean discounts? This is just what it should cost. Why can't I go get that? Why do I need you? And they could never explain it to me in a way that made sense, right? And again, me being ignorant, I wasn't afraid to ask, well, why is that, right? The other thing that really bothered me is as we were trying to understand all of this is they continued to blame our employees for our costs going up, right? Me, right? Well, they did this, so they're driving up the cost. Well, if they would do this and again, I'm thinking like, well, I don't know that, right? And how would they know that, right? So help me educate them, help me figure this out. How can you help me? And they would come up with these fluffy things that we'll do this or we'll do that or we'll drive these programs. But again, it just never happened and costs continue to soar. And at the end of 2018 into 19, we had an unfortunate incident with our broker. This is not to trash brokers, by the way. I'm sure there's some good ones out there. I have not had a great experience. So I'm coming from that lens and that perspective. But our broker made a pretty significant error that got us in trouble with the Department of Labor we incurred a fine as a result of that. And again, when I met with them to talk them through that, these were the folks that designed the plan. They were the ones that put it in place. I had the PowerPoint presentations they presented to our executive committee of put this in place. They designed this particular piece of it. And they wouldn't even say they were sorry. They wouldn't admit any fault. And so they were dismissed, as you can imagine, very, very quickly. And so from there in 2019, I started interviewing new brokers, right? And again, it was just the same crap, right? The same, we can get you the discounts. We can do this. We can do that. We partner with Dr. Smith at the surgery center, right? Well, it just so happened the week the guy told me that, I got a phone call, right? You've got to go meet with this Dr. Smith character. I'm like, who's this? Right? And Jay Kempton, right? And so we met at a local restaurant in Oklahoma City. I sat down, not knowing anything, right? What am I about to do? Very, very much the video you guys saw of, hey, here's the pills, right? And Dr. Smith starts talking to me about what he's done at the Surgery Center of Oklahoma, right? And Jay starts talking a little bit more about Kempton and what they do. And I don't know if you remember this, but I was like, that makes no sense. This sounds like mom and apple pie. I don't understand this. And he's like, I know. I'm like, no, I'm telling you, what's the catch? What's the catch? He's like, there is no catch, right? Because again, we've been trained that healthcare is complicated, right? It doesn't make sense, right? It just don't worry about it, right? But here I have an example of not only does it make sense, it's economical, right? And it's affordable. We had been, oil and gas has been going through a pretty tumultuous time over the last 5 years. So we've actually reduced our headcount fairly significantly. And freezing, right, pay, right, in many cases, but also too looking at we're going to have to make you guys pay more into the plan because we can't control these costs, right? And that That didn't feel good, right? I was running a benefits plan that didn't feel good. I didn't like it, right? Our employees certainly didn't like it. So left the meeting with those two, and I say those two mostly affectionately, because I just had a lot of things rolling in my head of, oh my God, what did I just hear? And I remember calling my husband and telling him, like, I don't know if this is real, but this is kind of crazy and it's kind of cool, right? So we immediately began working with Todd and his team and worked on putting a bolt-on pilot program of KPP free and adding that to our Blue Cross plan, right? All the while kind of doing this without telling Blue Cross what we were up to, because I was pretty done with them, right? And so we introduced this new plan first to our executive team, who just said, same thing, me, what the heck, this makes no sense, right? And even some people that were a little combative about it. I said, well, I'm doing it. So you have two choices. You can get on board, you can fire me. So take your pick, right? And so we did it, right? And then we rolled it out to our employees. And we had meetings, mandatory meetings, where Todd and team came in and talked to all of them. And we have a lot of scientists that work for us, a lot of people that are great at math that were sitting there doing the math as Todd's sharing, what the costs would be under this program, right? And again, this doesn't make sense. This doesn't make sense, right? But we try it, right? Try it. The other thing we did is we incentivized we also made those meetings mandatory, but we fed them, so it was okay. So it's good. Always provide food. And we also invited their spouses to come in. We did in-person meetings. We did virtual meetings. We did everything we could do to get that information out there. And like I said, made it mandatory. We also added an incentive to the KPP program that, look, if you go and work with our providers, and by the way, these are quality providers, not people that are in their garages, doing surgery. If you work with these providers, we will not only will you not pay a dime, right? You will pay $0. I will give you a cash reward for going, right? And funny enough, the people today, and most of our that take advantage of this plan, they don't even submit for that anymore. They're just thrilled with the program and they love it. So at the end of near the end of 2020, Blue Cross Blue Shield kind of made the decision for me. I called them and I asked them for our data. Give me my data. They would not give it to me. They would not give me a thing. How much is this costing? What are you making off of this? They wouldn't give me a thing. And to me, I thought, I don't want to work with a provider like this anymore, and told them, we're done. I'll send you a notice, whatnot. They asked, okay, who are you going with? What are you doing? I was like, well, I'm going with Kempton. I was kind of borderline threatened a little bit. You'll be back, blah, 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 whatever. And we've never looked back. And if you'll go to the next slide, I want to talk about this a little bit. This is pretty incredible. And like I said, I do want to point out that we have had a reduction in our headcount, but this is looking at our costs in 2018, 2019, and comparing to 2020, right? We've had an almost 70% reduction in our healthcare costs, right? Just comparing this 1 year to those 2 years, right? And then again, there has been a 47% reduction in headcount, but again, following a model that I'd seen where our healthcare was doing this, our healthcare was doing this, our costs were doing this, right? And it was phenomenal because our employees are happier. The anxiety around healthcare is gone that I used to have of, oh, I have to have surgery, I have to have this, I have to have that. It's easy now, right? So if you'll pop to the next slide for me real quick. So kind of next steps are we want to continue to adjust and refine our healthcare strategy. What I love, and if you guys think back to the first slide, this continuous improvement process, I'm actually finally able now to not only close that loop, but continue it. Todd, as an example, was just in here earlier saying, hey, we need to look at this, we need to do that. Megan is up my you-know-what constantly on, why aren't you doing this? Why aren't you doing that? Kelsey, this could be free if you do it this way. I'm like, well, tell me, I'm stupid. Tell me. I don't know, right? So it's critical that you have a partner that works with you, that loves what they do just as much. I mean, I can say now I actually love doing benefits, which is almost hurts me to say that out loud, but it's true. It's actually a really fun thing to be a part of now. We continue to engage our employees and survey them, and we really, really encourage them to share their success. In fact, we just divested of a property just last week, and we had some employees that went with that sale. And the first thing they said, as I'm sitting with them over a month ago, telling them this is what's going to happen, you'll be likely be picked up for the new organization, kind of walking through some of those FAQs. Do they know about Kempton? Do they have Kempton, right? And so they're advocates of that now. In fact, we're also going to be closing on a deal next month, hopefully, where we're going to be acquiring yet another set of employees. And our employees that I met with out in the field that are going to be, bringing those folks on, they said, we'll go out there and sell Chaparral to them. I'm like, well, what do you want me to sell exactly? I'm like, our benefits, and one of them popped up. He's like, yeah, my ankle surgery. Tell them about my ankle surgery. I'm like, I'm probably not going to do that. But I've never been in an organization where employees not only love their benefits, understand their benefits, they promote their benefits, right? They love it. And it's an incredible success story. And beyond that, we have had at least 2 instances that I know of where having access to healthcare, understanding healthcare, not being afraid of the cost has saved people's lives. And those 2 individuals, they want me to tell folks about it. They said they'd come down here with me and tell you all about it, but it's been a pretty incredible success story. And that one of those examples is as recent as 3 weeks ago. This employee was having some pain in his shoulder and wasn't sure, and he's like, well, I'm just gonna go get it looked at. Is that okay? I'm sorry I'm costing you so much money. I'm like, no, go. He had it looked at. As they were scanning, they saw something, they weren't sure, and he has cancer. And so we started him just this week on chemo and radiation treatments. But had he not had, this access, right, to this sort of thing, right, to where he didn't have fear and anxiety about getting it checked and also the fear of the cost, he may not have been here in a few months' time. So we're pretty excited about what we're doing. We love working with Kempton. That's all I have. So.
Hello, I'm Todd Rogers with the Kempton Group. We're a third-party administrator for self-funded health plans. And we do ask a lot of potential customers to Kempton to take the red pill, and that's fun. Some are coming from fully insured environments, and some are from a self-funded environment where they're vertically integrated with the BUCA monsters, and we need to unbundle that to the independent TPA and the independent stop loss, the transparent PBMs, maybe narrow network, we'll talk more about that, or maybe full reference-based pricing. But what's really interesting about our work is, I was even looking just like in a 2-year time frame, August 1 of 2019 to today, we've talked to well over 100 employers. And, that's a lot, but there's probably 1 out of 4 are ready to take that red pill and come on the journey to true self-funded, transparent healthcare. And so what I wanted to do today is tell you a little bit about what the profile is of somebody being successful using free market healthcare, what some of those components are, and then we've got some analysis of some really good success stories. So somebody that is going to be really successful at self-funded healthcare, has some of these spheres of influence, and we say extreme dissatisfaction with the status quo. And you see that little picture up there, that's a scary monster that's in the closet. And that's my analogy for a lot of employers look at their healthcare decisions as, man, that is something I do not want to deal with. Maybe how Kelsey once felt, and it comes around once a year and we're going to just, get this over with, and then we're going to stuff that monster back in the closet. We're not going to talk about it. We're not going to walk by that closet, and we're just going to ignore it, for another 365 days. And that's wrong. This is a daily challenge working on your healthcare solution. So you just can't ignore that monster in the closet because it will come back and hurt you, promise on that. The other is, viewing healthcare as a strategic business unit. We've read those articles that are, really eye-opening where Starbucks, they pay more in healthcare costs than they do buying coffee beans. General Motors, buys more healthcare costs than they do for actual steel on that. Warren Buffett once called them, they're a healthcare company that happens to sell cars on that. And it's always interesting, to ask employers, where does your healthcare spend rate on your P&L? It's almost always, in the top 5. Generally, it's second behind payroll on that. But a lot of times I get a really scary answer in that the employer says, I don't know. And so that means that they're not tracking it, they're not managing it, so they're not viewing it as that strategic business unit. But when you merge these areas together with a mentality to think different and break from the norm of the status quo being, okay, our healthcare costs went up, we're going to cost shift, we're going to raise deductibles, we're going to raise copays, we're going to reduce benefits, and then we can manage this cost. That's a failed way of thinking. It's you're hoping you don't really have a true strategy in place, but you need to break from the norms, and it might mean not thinking about the way you traditionally did in-network benefits or out-of-network benefits, and we're going to talk a little bit more about that. So some of the components, that we say the secret to spending less on your healthcare is just spending less on your healthcare. So how do you get to that point? It sounds simple, but it's true. here's the flywheel of, where we see employers, working in areas in concert to really get to that area where they can, spend less on healthcare. Number one, a culture of communication and education. And so I think, even from Medibooker and Kelsey, you are both, you're the tools that can help. That's fantastic. Kelsey, you wanted to educate your employees from day one when you found this solution. But this slide is a really interesting comparison of healthcare variants here in the DFW market. There's some common procedures on the left-hand column: colonoscopies, CT scans, knee scopes, different surgeries. Then we have in the green column the low prices of what that would cost, and in the red column the high prices. So you can go down on the last column and see the variance: over 800%, over 1,000%, over 300%, and so on. So what does that mean? An average 600 and over 650% variance. Let's compare that to something that we consume more frequently, and that's just a gallon of gasoline. So if the price per gallon of gasoline was $2.50, a variance of this scale would make it, where it's over $16 per gallon. And who in their right mind would fill up at over $16 per gallon? Well, nobody would, but we're very much informed because the gas stations have the signs on them. But if we ever saw, a gas station with a sign saying gas is over $16 a gallon, we'd immediately think there's something wrong here. There's a cartel probably manipulating prices. So, we would never do that. But why are employers not treating their employees with enough information on healthcare, to give them the information to be good healthcare consumers? Employees can figure things out. They're buying cars, they're buying houses and other complicated things, but they don't really have the tools to be able to buy healthcare at informed decisions. And we say that, a lot of times they are your partners in your health plan. And let's think about that. If a partner, is the business relationship, you'd have an operating agreement with your partners, which would essentially spell out that you needed to provide all information on this business relationship and your transactions to your partners. And I think sometimes employers can do a poor job of actually providing the information and education to their employees. The other area of the flywheel, very important, is the bundled direct contracting. So we've heard a lot today about the free market bundles and how they work. And so we really wanted to dive in detail. This is an actual, real claim of a free market bundle of a total knee reconstruction. So what we have is a claim of what it costs under a traditional payment model. And you can see, what is included and at what prices, but even more telling is what's not included. It does not include physical therapy. Does not include any complications if there's a poor outcome and the patient needs to revisit the surgery. It doesn't include any of those revisions on that. It's a giant price tag, over $170,000. But when we compare it to a bundled payment, and this is the claim that could actually occur, is that you see everything included in there, and you see that one transparent price. And that's over $20,000 for this total knee reconstruction. But I think that even at Surgery Center of Oklahoma, they do it for less than $16,000. So that's sort of an average bundle price in that case. One thing we do at the Kempton Group is when a patient needs care and we're able to direct them into this bundle, our care advocate team makes sure that they tell that employee that they are able to get this procedure for no out-of-pocket cost because their employer is paying 100% of it at a much less cost than a historical PPO allowable rate. And back on the profile of companies that really understand how free market healthcare works, we've had a current client that's told us, don't tell our employees what the cost of healthcare is. So that's somebody that's really not aligned in the mission, because we want these employees to know why they're able to get 100% benefit, and going through that kind of information is very helpful to them. They can understand it. Again, employees are very smart and they can figure it out. So the Ppo Networks, there's been a lot of talk on that already. And why is a Ppo network good? Well, it's a safety net, and that's what we're used to. But it's really to the detriment of the health plan and the overall spend. Again, if we're going to spend less on healthcare, we need to access it at lower cost. This graph really is telling in terms of applying to, a percent of Medicare. So if Medicare, is the largest purchaser of healthcare in the country, if that's our baseline, where are PPOs? Here's some average prices. Here's some procedures like knee replacement, gallbladder, hysterectomy, and you see in the dark blue that is the the billed charges. So that's that fictitious number that the PPOs want to tell you that they're able to get the deep discount from. Well, that comes on that lighter shaded blue there. As you can see on these procedures, you're really lucky if you can get your PPO below 300% of Medicare. It's oftentimes much higher than that. Some PPOs will be a little bit different, but less than 300% is a good price for the PPO. Well, let's compare that if we were paying it just on a reference-based pricing or a Medicare Plus program. So the percent of Medicare, if you're doing a reference-based pricing plan, is generally comes out to between 160 and 200% of Medicare. So if you're able to buy your health care not in a network as a percent of reference-based pricing, you've substantially decreased that. But by far, the best purchasing opportunity for the health plan is to do the KPP free. That's what the Kempton Group calls the direct contracting program, Kempton Premier Providers, and it's actually free to the employee, so no out of pocket. If you like KPP free, you can congratulate Meg Friedman right here that invented the term. But so that's the green bar that is showing what the price is as to a percent of Medicare. You can see that that's barely over 100% of Medicare, in some cases below, because the bundle offers that deeply discounted. So when you're offering the direct contract program, you really want to minimize your network spend. If you have a network, then employees should get the ID card that essentially says break glass in case of emergency. Try not to use that. Go to the direct contracting, do it as a percent of Medicare, and you're going to have better outcomes. So being able to, another huge component is controlling your pharmacy spend, and so there's a lot of consultants that have worked over the years that used to say that the pharmacy spend years ago was 10% of the overall health claims, and now it in many cases exceeds 25 or 30 or approaching 40% of that. So there's a lot of good pharmacy benefit manager programs out there that are transparent, and those are good to work with. They're going to give you better opportunities, returning plan rebates to the plan. That's something important to focus on. But even more importantly than that is engagement tools on being able to help your employees understand how they can have better opportunities to save money, and the plan can save money if they can have better opportunities on their specialty med purchases or moving from brand names to generics when available. So there's a lot of tools that you can use data on to optimize your pharmacy controllable expenses. And then also direct primary care is a key component with free market health plans. Well, this is an example of a 100-employee group in Omaha, Nebraska that's seen their purchase of healthcare decrease over 60% since bringing in direct primary care. They've seen their pharmacy spend go down. They've seen their emergency room and urgent care visits go down significantly. So the direct primary care, I think a lot of times at its initial look, it comes out as that looks very expensive. And I think direct primary care memberships we see per month, per employee are generally $50, $80, $85 sometimes is a range that we see. And that does seem like a fairly big number, $700, $800 or $800 annually per employee. That could be a lot, but when you look at it holistically in terms of everything it does for your health plan, it gets people to a really good primary care physician that helps them prevent the long-term events. It can help, in states that are, eligible, you can source generic meds, to your patients without ever hitting your plan cost on that. And it can help, redirect into the good value providers, the ones you have direct contracts rather than into the large health systems, which is going to be really expensive. And moreover, its studies have shown how much employees value the convenience of direct primary care, the same-day appointments, the telemedicine health. So when everything is running well in a direct primary care environment, you can have a substantial amount of cost decrease. You look at that membership as an investment in controlling your costs more long-term. So a couple case studies to look at. We're going to look at it in kind of two levels. For CEOs and CFOs, we wanted to talk about a longtime client that the Kempton Group has worked with. It's a public entity of about 1,100 or 1,200 employees and retirees on a plan, and they've had a real strong internal culture of being able to talk about using the direct contracting program, the KPP free in this instance, and so they've really done a lot of education and communication, so hit a lot of the right things on that. And so if we click on the results, this gives a great detail of over 3.5 years. And the blue bars, show their savings from the PPO spend versus the direct contracting and the Kempton Premier Provider. And then the green sort of tracks their utilization. And so if you just looked at it in general from the beginning to the end, that line is going up. So what we're seeing is that the more utilization of direct contracting, the more savings. We see a little dip in early 2020. We know that's COVID related, but that line is going up. And then breaking out on the detail actually shows their categories. And so, imaging is it's a lower dollar in general ability to save, but what is really impressive about this group is that almost 30% of their utilization, they are hitting a lot of these, so that's great. They're hitting it on the very front end. Then you could see, what would be more expected, some of the orthopedic procedures, while less than 5% of the total use there, the percent savings are more than 25% on that. So orthopedic and cardiac, but a lot of different categories here to be able to show the overall savings. So this client has had an opportunity to save over $6 million in that 3.5 time frame by being able to spend less on the Ppo networks and going to the direct contracting program, a result of the education, and the communication that group has. So we can really see that the flywheel is working in an impressive way in this case. And then for average Joes, let's not forget that, healthcare, the spend, that was a great number to go through, a lot of dollars to think about, but let's just think about what it can mean in general. And this is a real life example that just occurred a couple weeks ago with a Kempton client that a plan member found out on the same day that he needed to have a medical procedure done and that his trailer home that he lived in had black mold on it and had to be replaced. So bad day for this member. He did call into the Kempton group and talk to our care advocate team and learned that he could have that medical procedure done at no out-of-pocket cost. His plan was going to pay that at 100%. And so he was very excited because now he could go get that. He had just enough money to go get that trailer home that he had to have replaced. And so I'm going to read exactly what he said to our team, but he said, with so much bad in the world, you, meaning Kempton and his employer plan, are doing a good thing, and I cannot thank you enough. So, these are real live examples that work well for CEOs, CFOs, and average Joe. So the last slide takes us to average Joe, happy that he's able to get that new trailer home. So. Any other questions? I know we have a DPC resource in the room, Sharon Hodnett. Terrific. I know you've provided that case study. You're also working with a university in Oklahoma that's going really well. So questions for DPC? Oh, Kelsey? Yeah.
Kelsey to Kelsey.
Great paper. So whenever you're talking with your employees, what do you do when an employee says, well, why are you limiting where I can go? I don't want to go to that doctor. I want to go to this doctor over here. How do you respond to kind of a pushback or to somebody who might be scared to the change?
Yeah, I think, well, first of all, being in Oklahoma City, we're really lucky because we have a really great network there. A lot of people that have bought in, to what Kempton is doing and the surgery center and whatnot. So that helps a lot, first of all, that we have a lot of providers where people can go. The first thing is, I talked to them about is just the economics of it's going to cost you $0, right? We had an employee who recently had open heart surgery. So all the things leading up to that, the surgery itself, some of the rehabilitation that he needed, that total amount was $35,000 to the plan. I know most of you know what open heart surgery costs in the real world, right? And that member saw a $0 balance right at the end of that. And also, again, just thrilled about that. But, so we start with the economics and we talk about that. But one thing that I have found to be more important than anything else that I've done in communicating to people is hey, talk to your peers, talk to your people that have done this, encouraging people that have been through this process with Kempton, right, with the providers, talk about your experience, right? And that's the thing that's so great. I don't know if you guys have read Ken Blanchard's book, The Concept of Raving Fans, the concept of you get customer service or experience that's so great. You not only want to go back, you want to tell everyone about it, right? That's a concept I've really tried to drive through our organization in the way that I do business with my people, right? So really, it's just about talking to them, giving them the economics that hit their wallet. I also try, if I'm talking to a male member, I try to get hold of mama at home to explain to her it's $0. That's usually really effective and helpful. It's true. And also you're gonna get a bonus on top of that, right? But the single most important thing that matters is everyone hearing about, this is a great experience, you should use this, right? And it really just comes down to, I hate saying education because that sounds not quite right here, but communicating and talking about it and sharing your story.
Hi, I'm a DPC doc, and I've been doing this for about 4 years, talking to employers. So I would like to hear, I thank you for your presentation. And I want to ask the employers in here if they can give me some advice on how I can talk to them to take them to the next step, like you went to the next step. Because I don't know, we talk to so many people. I appreciate you presenting the profile of an employer that's really looking. That's very helpful. So I'm just, we present this great value, and we've seen it through this whole conference, the great value. And I'm like, to the point that I'm just ready to get out of here and go, because what is it with these people that they don't see it, So if you employers have some more feedback, I'm all ears. Thank you.
I would say, and I'll let other people in the room speak up too, that are kind of going through a similar transition right now. It's not, like I said in the beginning of my story, I did not understand our plan. I did not understand healthcare. And so I think it's fear and stepping out and doing something different. For me, it was. And it seems like, so what I just mentioned about the employee needing some guidance and some help, I had to talk to other people about this and tell me about your experience and how did you do this? And leaned on Kempton to ask, what are some things that I can do to better understand this or incentivize the people that I'm trying to explain this to? But my guess, and this is just from my lens and my perspective, is just I didn't understand, and healthcare has been made to be scary for a reason, to keep us in the dark, right? So, but I would ask some of the other folks in the room if you have any thoughts or experience on that.
I also want to say, I think you raised a very important question. In the audience, we have the employer side, and then we have the provider, if I may use the word provider side. How do the supply and the demand side meet? How do we cross that bridge to make it work? Right?
Well, I would speak to that a little bit because that's how I view my role as a consultant, is bringing all these pieces together for an employer and helping those employers understand the value proposition of direct primary care, of value-based pricing, of all of these components. And what I see out there is I'm one of 1,000 that is actually engaged in this process and trying to do that. And to answer Dr. Mitsugamba's question, how do we talk to employers? I will say it's direct primary care has been the most difficult conversation. I've had to convince employers this is a key component of the whole thing. And there's two pushbacks that I get. One is it's a relatively expensive upfront cost with savings that are hard to quantify. I mean, I believe it. You just have to believe, right? I mean, I know it. I know it's going to happen, but I can't produce a spreadsheet and a graph and demonstrate conclusively that direct primary care is going to produce these cost savings. And the second thing is, well, people already have their doctor. Yes, I understand that, but they hate it. But you don't understand how little they like their primary care situation. So I will say that's the biggest challenge that I've encountered is getting somebody over that hump to make the investment and pay for direct primary care. But to answer the other question, how do we connect all these pieces? I mean, from an employer standpoint, you know, Kelsey had a unique situation meeting directly with Dr. Smith, and if you don't believe after you do that, then you know you're not very smart. But
I'm not very smart.
most people don't have that opportunity, and so they're relying on a consultant, a broker, advisor to do something for them, and most don't, and that's just the way it is. And so that's all my comments about that.
You, Todd, did have a slide that was featured KP Ninja. They do a lot of research, so I think there's more research being done to show these metrics or statistics about primary care, right?
Yeah, there is, and I would say education is the key. And you know, there's a lot of times we have talked to employers over a multi-year period, and you know, there is a lot to learn, a lot to absorb, and you have to find the business when they're at the right point in their life cycle to really digest and understand all that. And it does have to be the right profile. Well, Greg, you and I talked to an employer last year that, you know, they were private equity owned and run, and this was not really meaningful to them, I don't think, because they looked at it at an entirely, different prism and from their management standpoint. And so, the CEO was telling us if he has to have orthopedic surgery, he's going to go to the doctor who works for the Dallas Cowboys no matter what, and so he was not going to look at any option on overall cost containment. So that did not fit the profile. And so, so we move on. So there's plenty that do, but the education is the key to get there.
I'm sorry, hold on a second.
As a DPC group, we have 3 DPC clinics, and our barrier with employers is generally finding the good consultants. So most brokers and consultants don't want us in the room, no matter how much savings we can help drive to the employer and better care for their employees. Most consultants are paid on the cost of the plan, and the more the plan costs, the more money they make. And so there are just such a small handful, like Greg, that are really trying to do the right thing for the employer. And so the employers that we've worked with, and we've got some pretty large employers that are clients in the Oklahoma City area, every single one of those relationships for us came by somehow connecting directly with the employer, educating them, and then they went to their broker and said, we want this, you figure out how to make it work. And we have very few clients that came to us through the broker or consultant. Almost all of it is our relationships have been, because most of the consultants aren't really looking out for the client the way that they should be. And so there's just a small handful. Like, we desperately look for more that we can work with that are free market minded and truly want to do the right thing.
All right, okay, for the video. All right. So most of what I'm hearing, these case studies, are the groups are close. Oklahoma City, they're all in one area. I have a group of 107 that are spread out over 26 states. Would anything like this even possibly work in a situation where people are all over the place, and in some cases in very small rural areas? Because everyone can work from everywhere now, right? So these folks are all over the place.
Speak to that.
Yeah, sure. We have a group. They have about 150 spread in 7 states. So then traditionally you're with the bookers, and they have networks all over the country, and that's an easy way to do. But then you can't bend your cost curve. You can't bring that down. Patient advocate services quality is low, so you kind of just throw your employees into that big ocean of network, but you don't really get the results. One way we found out that was helpful was to leverage the patient advocate who is there on the phone, navigating those employees, whoever they are, wherever they are, and trying to help them connect to the right providers at the right time with the right cost. That was helpful. But ultimately, I think as an employer, you probably have to speak up, like make those demands from your benefit consultant. Like, this is not good. I want better plan design. I want a better TPA that can work with me. Can you help me find the right patient advocacy services that can serve, guide my employees? And then do that. So what I'm saying, if you want those different pieces, like Todd had that wheel, all the different pieces, most likely the progressive ones don't have an established national network yet, right? So you gotta make a choice. Do you go with the traditional Booker's network where it doesn't really solve the problem? Or are you willing to go with some of those solutions? They may not have a point of solution at each point of those 26 states. But then you have some services holding hands of your employees and then bend the cost curve down. Does that make sense?
So I am a broker. So what I've done with this group is we have a health share that is offered to everybody. And then, of course, we have a THCS. Surprise, surprise, right? It is the network that we use for those individuals. But going with this concept would even be much better, in my opinion. However, I have the concern of having enough providers that would buy into this in the small rural areas, and even some areas that are not necessarily small, but places like Nacogdoches, Texas, where they can't even find anybody that's going to take Blue Cross Blue Shield. So what do you do in areas like that? And will the Kempton group, will they work in areas like that? Will different folks find providers?
A little bit. Well, I said Oklahoma City, our employees are mostly in rural areas, right? And so you would be surprised by the number of doctors, facilities, surgeons that are willing to do a cash price deal, especially when they, whenever they're told about how quickly they're going to get paid and the negotiated amount. Because the amount, it's not take this or else, it's a negotiated amount, right? Correct me if I'm wrong, stop me.
That's a good deal.
Just stop me. But that was another question that I had for Todd before we did this. I'm like, okay, Todd, well, what if I'm skiing in the mountains and I break my leg? So then what, right? How does that work, right? And he provided countless real life examples of how they were able to connect with facilities, physicians and whatnot, and how quickly they were able to come to an agreement on how this would work. So it has worked. It's worked for our employees. The other thing that we've done too is that if we identify an employee in a rural area, but we can get them a better deal, better service, maybe in the city, right? We pay for them to come to the city. We pay for their hotel stay if needed. We pay for their mileage. And it's still, as you saw with what Todd shared, significantly cheaper than running through, any other program. So I'll let you speak to that now, but it can work and it does work.
Yeah, from the TPA side, there's the Kempton Premier Providers, that's on our website, and you'll see those are pretty much where our clients are. But if there's areas, where we don't have clients today, but a new one comes in, we have a proactive provider relations team that will work with, James, chapters maybe in some of these, the Free Market Medical Association chapters is a good starting point. There's also, I'd say, a lot of other fish swimming in the same direction of this, free market sea. And there's other ways we can find these transparent bundles, through other aggregators. So there are opportunities. You may have to uncover some rocks. There's a great DPC physician in Nacogdoches, Texas, Dr. Jeremy Smith, if you're familiar with him. And, so that's a starting point. It's a brotherhood, that one good contact with a DPC physician can lead to 3 or 4 providers and, folks that are active in the FMMA chapters. So I just encourage you to kind of keep working at it, but could be a challenge as spread out as that group is, but there are solutions.
And this is kind of growing organically, just based on specific cases that come up. Like Jay was just telling me a couple days ago about maybe a facility in San Antonio is not affiliated with FMMA or KPP, but there was one of your employees under your plan that went to this facility and they were going to charge some extravagant amount. So Jay gets on the phone and calls them and they say, oh yeah, we can do a bundle price. And then now they've sort of organically joined the movement, right?
Yeah, I think that specific example, Melissa can remind me, but I think Jay saw a claims report of something outrageous and he picked up the phone to that provider and said, let's get a bundle done right now before that claim had actually processed. So that probably would not happen had there not been enough discussion on what this movement is, the work you're doing in the free market, just to be able to have people understand that this is a good way. The provider gets paid quickly.
From the DPC perspective, in those rural areas, like we have clients that are a couple of hours away from our clinics. And for them, they're like, we don't have health care out here anyway. So we have to drive to the city most of the time. And so we have them come in and establish care at least once. And then when they need something, they can do, text conversations, video conversations. If they need lab work, we can just send the order in to a lab near them. When they need prescriptions, we send them into the nearest pharmacy to them. And then, they're always like, I'm in the city every couple of months anyway to see my kids or whatever. And so they schedule those follow-up appointments when they're going to be in town anyway. And they love it. In fact, we had one who works at the bank, and his bank was recently bought out, and he's losing the KDAP plan with his DPC doctor through Kempton. And he is just like, I don't care what it costs. I will pay for this myself. I live hours away from good health care, and I do not want to lose this. And so, the rural areas, the technology takes away the challenge of those remote areas, because again, most of them don't have great health care options if they're out in the rural areas anyway.
Yeah, and we have that in San Antonio surrounding area, and Dr. Rogers' clinic has provided that same type of service. I have clients that I have sent to his clinic, and they live an hour and a half away, and so they do the same thing. They come in for an initial visit, and then if they need to talk to him, they can video or they can talk to his office, get the same thing done. If it was in the San Antonio area, I would know what to do. But whenever they're in 26 states, it's like, oh my gosh, now what do I do? I got to find something else that's going to work. So a lot of them just choose just the health share and nothing else. And I don't like that. I want them to have other options, because there is not always good care. And I've had people tell me, yeah, if I go see a doctor, it's 2 hours away anyway. So, that's not cool.
This employer is a church. They have 36 locations in 11 states. And we put together a network of 18 DPC affiliates that are in the cities where all of their locations are. And so it's our client because they're based in Oklahoma City. And so we did the work on our side to go out and find the DPC clinics where all of their locations are. And we learned a lot. This was our first one to do one that large. So we've learned a lot from it, but they're such believers in what we're doing. They're like, we want every single one of our employees to experience this kind of health care. And so, if any DPC that you're working with can help find those other DPCs in the areas where they're not, and they can help you put that network together. And so it's been neat for us going out and connecting with other DPCs in other states and learning the nuances of different areas and things like that. But really the heart of caring for people and doing the right thing, transparency, relationship-based medicine that's the common thread through all of them.
Hi, my name's Eric Inman, and I'm. Is this on? It's working. I just can't hear. So I had a question for I think Kelsey and maybe Todd could both speak to this. Ron Panicki and myself, we're physicians who are starting a free market surgical solution for outpatient surgeries in Indianapolis, much similar to the Surgery Center of Oklahoma. Kelsey, when I heard you talking about the bolt-on to the Anthem plan, we've had similar conversations with some of the employers. A lot of employers are with the BUCA, the BUCAs. And so I guess I just wanted to hear a little bit more about that. You know, you trying to add that on. What was that? What did they have? Was there pushback from Anthem, and how I guess how does it how best should we navigate that? Is my question.
I didn't tell them.
Okay.
And they didn't know because they didn't bother to understand why is their data suddenly shifting. I don't know if that's the right way to do things, but they certainly weren't transparent with me, so I had no interest in playing ball with them anymore, right? So the bolt-on was really just a baby step in, right? And so my thought was, let's try this for a few months, and if we get the participation, if I see our cost shifting, we'll go in a little bit further. But for us, it was really helpful because it gave us a chance to practice before we dove mostly all in. We still have one more step to go, but to go to the reference-based pricing. But it gave us a chance to practice and as an organization, see if it's something that worked for us and worked for our culture. I did not communicate anything to our providers on what we were doing. And it worked out well. One thing that was a bit of a challenge for us was at the time we did offer a high deductible health plan. And so the KPP free model works, but wouldn't be technically a zero cost to the employee until they met their deductible. So I can let Todd speak to that a little bit more. That is something just to be on the lookout for. But as an employer, it was nice to be able to baby step into something, try it, bolt on, see if it works, right? And then from there, it took us 2 months to say, okay, we're in, right? Todd, let's sit down and let's go all in on 1/1, right? So it was really helpful.
So the BUCA carriers, they have anti-steerage in their contract. So you can't get out of their, PPO. They're locked in on that to come to yours. The vehicle on the bolt-on is creating a secondary plan document. It mirrors the other plan. Eligibility and coverage is the same, but that allows you to then access, the direct contracting providers. And, Kelsey's correct. You can't have, the first dollar coverage for an HSA participant. They can still access, the lower prices through the direct contract through their own HSA money. And those people that could get the MRI for $300 versus $3,000 are going to love that. So it's compatible in that way. But you ultimately changed your plan design to be able to get to that point. So we could talk more if you kind of want to learn how.
I discovered in that moment that the high deductible health plan and the whole HSA thing is just a big scam. Too.
Right. Yeah,
it really was. It was just
we've run
ridiculous.
into that too, and talking with some of the people about the HSA. So I would like to talk to you a little bit more about the HSA.
And it's kind of a good point. We have found, on reference-based pricing plans, really a good deductible for a plan is around $1,500 on that. You don't want a high deductible plan with a reference-based pricing because you want to be able to tell the providers we're giving you a good deal, Medicare Plus on here. Plus, you're not going to have to be on the hook chasing down collections on a high deductible plan. So that's really something I don't think even talk enough about it. We talk about overall plan savings, but we're enhancing the benefits, and so that's what a lot of employers and consultants have put in for their clients is a better benefit plan at a lower cost.
Thanks.
Thanks, James.